Hey everyone, my name is Marianne Pizzatola, and I am president of the New York City Organization of Public Service Retirees. You might have heard of us. We are the organization that was founded 2 years ago in New York City, and for its sole purpose was to protect and defend a retiree's health benefit from being diminished. Because at the time, 2 years ago, 2021, the city of New York was trying to force all retirees off a choice of healthcare plans that they had for decades and force them into Medicare Advantage. The original plan, I'm not going to get into specific vendors because they're basically all the same. It doesn't really matter who they are. They all basically work the same. You're going to be sold, and this video will be tailored to unions, active unions, to retiree organizations of those unions, as well as municipalities and employers that are actually both all being approached with this issue. You are going to be confronted by a actuary or a consultant, and they're going to say to you, hey, I could offer you a savings. You could save a lot of money. We're going to give you this healthcare plan for your Medicare eligible retirees, and it's going to have a bunch of perks. And guess what? It's going to be free. Now, we're New Yorkers. Normally, you ask us, no New Yorker would ever believe that you could get something that's better than what you got, especially a government-run program with perks, and it's free. You know, in New York City, we actually joke that's a taillight guarantee, comes with a taillight guarantee, or yeah, I got a Brooklyn Bridge to sell you with that. But unfortunately, unions and municipalities all around the country are snapping up this byline, and they're falling for the big lie. It's better. All doctors accept it. You won't lose your doctors. You could see specialists. You get silver sneakers. You can get a Fitbit. You'll have free rides home from the hospital or to your doctor's offices, 12 or 24 a year, specific mileage, like 12 within 10 miles or 25 miles or 60 miles. All of them offer a little something different. We'll give you meals, 14 meals when you get discharged from the hospital. But what they're not telling you is for all those perks, you are giving up the one thing that you needed your healthcare for: pure access, direct access to a medical provider of your choice, to hospitals of your choice. In this situation, whether it's an HMO or a PPO, they're going to act the same in that you don't any longer have that ability. They're going to say you do. They're going to say you don't have the ability. You have the ability to see any doctor that you want, whether they're in network or out of network. Well, then why do you have an in network, out of network? If there is no network, if there's no other issues or there's no hurdles for me to jump through, then what's the deal? And actually, there's a lot of deals. And you're giving up your direct access to healthcare providers, hospitals for a perk. There is no value worth that. Trust me. So especially as you get older and you need more doctors, then the networks that they have, they're very small. Medicare can say like 90 to 94% of doctors in America accept traditional Medicare. No Medicare Advantage insurer can say that. They will give you some BS line like 88% of the doctors that retirees in your plan currently see will accept our plan, is what Aetna told our retirees and our unions. And we were like, wait a second, there's only 183,000 of us. You're saying that 88% of doctors that we currently see, 188,000 of us currently see, are in the network. That doesn't make any sense to us. Oh, well, don't worry. Another 8 or 10% are known to accept Medicare Advantage for payment. And we said, what does known to accept mean? Known to accept, the definition according to Aetna, vice president, was that they were known to accept Aetna for payment at least once in the last 12 months. Well, if they were known to accept the insurance company for payment once, doesn't mean that they're going to come back a second, third, or fourth, or 10th or 100th time. And just because that vendor, that doctor, that provider is in the network today doesn't mean they're going to be in it tomorrow. Look, a major hospital in Oregon just pulled out altogether, and they're telling their seniors in their community, do not purchase a Medicare Advantage plan coming up in this October's open enrollment. We will not accept any MA plan, not just by vendor, any. And there's reasons for that. So I want to keep these videos short so the people that really need to watch them actually watch them. And I want to bring you to one of our fact-checking documents. And of course, you know, there's many. Okay, this document we did as a fact check consequence. We wanted people to understand exactly what they have with traditional Medicare and what they would be getting that would be different with Medicare Advantage. And we wanted this to be a one-page document. And it's a lot to get into, but there were a lot of differences. But this is matter of life and death. This is people's life. So this is super, super important. Okay, so let's get into this. Traditional Medicare has very limited prior authorizations, such as for transplants, so we have direct access to needed care. When your doctor says you need something, you go get it, whether it's a test or a procedure. Prior authorization is permission, okay? So you need permission in prior authorization in Medicare Advantage that you do not need in traditional Medicare. Medicare Advantage, we refer to that as MAP, Medicare Advantage Plan, MAP, requires prior authorization, PA, on many tests and procedures. The Health and Human Services Office of the Inspector General found that Medicare Advantage plans insurers delay and deny care wrongly. The Aetna contract, which was ours in New York City, puts the prior authorization in the hands of the MLC, which is our union umbrella group, and the city, and they can be changed by them every 2 years. Now, we were frustrated by that because we know that the only reason that they did this in the first place was because they wanted the value of our healthcare plan to use in collective bargaining. What is to say that in this almost 6-year contract that every 2 years they're not going to be pulling out value for their collective bargaining, saddling us with more prior authorization as we're getting older or more disabled, and then they're taking the benefit in their raises? That's not the way this worked. We earned our healthcare. Every retiree earned their benefits. No union, no retiree group, no legislator, no state, no city, no anybody should be diminishing the public health benefit of traditional Medicare. This beautiful gift that we were given by legislation in 1965 by President Lyndon Johnson with the help of labor and Martin Luther King in advocating for this. And then we've paid for it in every single paycheck since our first paycheck as a Medicare tax. Look at your pay stub. You paid for this, not to be privatized. So let's continue. There are no networks in traditional Medicare. You can see any doctor you want anywhere around the country, anywhere in America that accepts traditional Medicare. And that, like I said to you, that's about 90 to 94, 96%. Medicare Advantage plans have networks, and many providers do not participate, even if it's a PPO, because a lot of these insurers like to go, oh, but it's a PPO or it's a passive PPO. That's another, or an LPPO, which means that they've taken these little limited networks and they stitched them all together to make this big network because their network wasn't big enough to cover where it needed to, like America. So that becomes a problem. This limits who you will see if they don't accept this insurance, especially if they won't accept the plan for payment either. You're basically screwed because you have to pay the doctor if the doctor refuses to either bill or accept payment from the insurance company. And then this is an issue because now you're paying the doctor and then you have to hope that the insurer is going to reimburse you back. I don't know about you, but we don't have the money to do that. So patients' own providers determine your length of stay in rehab and skilled nursing. Now, in the contract that we were given, and yes, we were given the Aetna contracts. Actually, our legislature was, because they had to look at them. They actually demanded them and told the union and labor relations, we're not going to do this unless you show us the contract. So Medicare Advantage determines the length of stay in rehab and skilled nursing facilities, and they do often deny it. And we know that for a fact, and we had many affidavits in our litigation to that effect. So that is something, especially when you get older, you get discharged from the hospital, and we'll talk about that in another point, why that's important in a minute. Retirees are not responsible for out-of-pocket expenses, even if the service is deemed not medically necessary, by Medicare. At that point, the provider is held financially responsible. Retirees don't pay for services after the deductible. Now, in our plan, you have a deductible. In the plan that we had in New York City, Medicare, you have a deductible. Everyone in America does. It's like $226, I think. And then our little supplement plan that pays that 20% that Medicare doesn't pay had a $50 deductible. Once we met those two deductibles, there was no insurance, co-insurance. There was no co-pays. In Medicare Advantage, retirees are responsible for payment to out-of-network providers who will not bill the Medicare Advantage plan directly. They will have to submit for reimbursement, and if the service is deemed not medically necessary, you will not be reimbursed. Now, Aetna suggested that you ask for a pre-visit confirmation to ensure that they will pay, which is basically the same as a prior authorization. And they also, in their contract, have what they call retrospective review, which even if after they tell you that they're going to approve it, they could later deny that. This point to us was super serious because we have a lot of people in this situation. Retirees in CCRCs, is continuing care, retirement, or residential communities. This is like a life plan that you end your life with dignity. You live it very actively until you get older or more disabled, become infirm, and you're not able to. And you transition into this facility from independent to assisted to memory or nursing care. This is a really good way to live, especially when you're not looking to burden your family with taking care of you as you get aged or infirm, or you don't have family to do that for you, and you want to make sure that you live your life to the fullest and with dignity when you need it. So that is what a CCRC is. Well, retirees and CCRCs are required to maintain their traditional Medicare and a supplement. You literally sign a lease-like document when you move into these communities. If you're forced into a Medicare Advantage plan, these people would either have to leave their community or pay for insurance outside the city, and they would lose in our situation, we were also reimbursed our Medicare B premium because our statute requires that the city were to pay the full cost of our health coverage. So we would have lost that. And in some of our unions, we would have lost that retirees that have union welfare funds, that's prescription vision and dental benefits. We would have lost those if we chose to leave the city healthcare benefit, which is exactly what they were trying to do to us at the last stage. They stripped us of every choice of healthcare. They told us the only choice that you have is Medicare Advantage. And if you don't take it, you have to waive your rights to your city health benefits as you earned. And then you would go back to traditional Medicare. The issue with that is, though, depending on where you live, how old you were, if you were over 65, you'd be subject to underwriting. If you were under 65 and depending where you live, you might not be able to purchase a Medigap because many states don't offer Medigap plans for the disabled under 65. And then if you could get into them, even after the underwriting or the age issue, you had to make sure that you could get in even in the middle of the year outside of open enrollment, and you could afford them. In the state of Arizona, I have a retiree who was not able to secure one at all, and she was under 65. Arizona wasn't giving her a plan. I have a retired firefighter in Florida who is about 58 years old. He is disabled. He had a kidney transplant. His doctor and hospital both told him, we will not accept your Medicare Advantage plan. We don't care what kind it is. If you need another transplant, you're going to need to find another doctor and another hospital. He went to get an AARP quoted Medicare supplemental plan. It was $800 a month. Our current city plan is $200. So this tells you that you could waive them forcing you into this MA plan, and you would go back to traditional Medicare. The caveat is you may not ever be able to get a Medigap or supplemental plan, and therefore you would then be paying full 20% of your insurance. This is squeezing you, the retiree, who served your city, served your state, served your municipality, served your employer, your union, and now being squeezed between a rock and a hard place from a federal public health benefit that you were promised and paid for your entire life. And yet the insurance company is selling this to your legislatures and your unions as this is a great deal because it saves the employer money. And then the unions are being told, do this to your retirees, and then you could use that money as for your raise. We've had many attorneys tell us that this is how it's been working, and we've even seen some of this. So these are the things that you need to look out for. Another big issue, our unions in New York City, most of them offer a welfare fund drug plan. So you don't typically pay for that. It's a free plan. There's no premium, but you do pay co-pays on your drugs. You're also, because you're in traditional Medicare, you can purchase an outside PDP, a private drug plan, on the marketplace. They usually cost about $60 to $80 a month. They're very inexpensive. Yes, they do have copays, but you're specifically looking for an insurance plan to cover like your specific drugs. I have one retiree. She purchases a Part D plan, a drug plan on the marketplace. It's under $30 a month. It pays for a drug, one of her many, but this one drug, her husband's union drug plan didn't cover. It was about $13,000 a month for this one drug. So knowing that she needed this outside drug plan, this plan happened to cover the drug, and the cost for the drug was something that they were struggling to handle, but at least they could. At least then our welfare funds were preserved, because one of the rules with the Medicare Advantage was that you could only have their drug plan or the union plan. If you didn't have a union plan, or your union plan had a low maximum benefit to it, like theirs, I think it was $10,000, she would never, or $24,000, she wouldn't get out of like the second month. So she would have needed a supplemental plan, a supplemental drug plan, an outside drug plan, to pick up where her plan would now have picked up, because she would never have even bothered using the union plan. The issue with that with us was that you had to exhaust the benefit first for the union plan, which would tax the union plan. That would drain it for all of these people first, sucking all those funds out of the union welfare funds, and then allowing them to move into the plan that they purchased by the insurance company, by the Medicare Advantage company. Now, the problem with that is it also came with the premium, but the premium wasn't $6 or $20 or $30 a month or $79 a month. That plan was $135 a month. And knowing that plan was going up, because they told us that it was going to start at that, but because of the Inflation Reduction Act, they have to make their money somewhere. They're going to jack the price up. Which they were doing already from 104 to 135. So yeah, may not be paying for the drug, but they're gonna sack you somewhere else. And that is what I was just explaining here, was retirees and union welfare fund benefits who purchase the high option rider for drugs have to pay for the rider beginning in January. That's the Medicare Advantage drug plan, but you can't draw from it until your union welfare fund allotment's been exhausted. This will cause the welfare funds to drain and retirees to pay a premium for a plan that they're not able to use. If the welfare fund plan does not cover the drug, the high option rider can't be used, and the member will have to pay the full cost out of pocket for the drug. The drug rider premium per person for Aetna was $103 for 2023, and then it bumped up to $135 for 24. And the plan premium is higher than the current drug plan that they currently have, and so are many of the drugs in it. This is another reason why people didn't want this. These plans also talk a lot about perks. Perks, really, for most of us, we don't really want them and we don't need them. We don't really care. Many of us don't wear watches. We're retired. We don't wear Fitbits. And for many of us as well, it's been identified as a creepy little thing, especially with AI, that they can track you or, consider you a higher risk because you're more sedentary, or some issues that definitely people don't want in their life. And then they also don't want the packaged meals after hospitalization. You can always get Meals on Wheels or Access-a-Ride in your community. You don't need this from your health insurance. Strictly healthcare should be for healthcare. So that was that. And the last issue is age and pre-existing conditions are not an issue in traditional Medicare, but securing a Medigap plan like our current senior care, if you're under 65 or disabled, or with over 65 with pre-existing conditions, will be subject to underwriting if approved. Premiums can be very high. Under 65 years old may not be issued a plan. And if you are in a Medicare Advantage plan before, like if you were ever tried one before, you don't have a trial right anymore. You're stuck in this plan then for the year. You're not going to be able to get out of it. So you're giving up so much. The employers and the legislatures, I get these videos from unions and retirees all the time saying, my union's trying to do this to me, or my legislature's trying to force this down our throats, or our personnel office is telling us this is great. And that's because the insurance company stands to gain billions of dollars from Medicare by overbilling and claiming that you're all high risk and upcoding where they shouldn't be. And all of these companies, and we'll do that in the next video. Many of these insurers are under investigation by the Department of Justice, not just for wrongly delaying and denying care, as the OIG found, but by the DOJ, the Department of Justice, for what they call upcoding, where they come to your house under the guise that they care about you and want to spend time with you and help you. And then they report back to the insurer that they consider you a higher risk and that they need more money from Medicare. This will drain the federal Medicare trust. And if you're also worried about protecting Medicare so that it's available for those legislatures that are forcing this down your throat when they're ready to retire, they'll be really disenfranchised when they realize that they forced this upon you. It caused the drain of Medicare because there is overbilling in this process. Even Medicare has identified it and has started to implement that process to go after those insurance companies for that money back. And it is in the billions. The next video we'll do on that issue, we'll start to put some of the clips when we went to Washington, D.C., to Capitol Hill with some elected officials, and you can hear the stats from those little short videos. But we're going to end this here. This is basically your pros and cons. What is the difference between traditional Medicare and Medicare Advantage? And this is across the board, no matter which plan you're in, whether it's United Healthcare, whether it's Humana, whether it's Cigna, whether it's Aetna, whether it's Empire, they all operate the same. And then they'll say, it's custom made especially for you. Well, really, the only thing that makes it custom is the different perks. But basically, they operate all the same. And sometimes, like with us, they suspended prior authorization in about 72% of the prior authorizations, but those can be put back in every 2 years, especially when they wanted the value. I mentioned that earlier. So note that those plans can change, and where right now federal Medicare is in the hands of the federal government, and it would need an act of Congress to change it. Medicare Advantage can be changed by your union, your former employer, or your legislature. Whoever holds the contract with the insurer can change it. And if you all do not have, like retirees, do not have a seat at the table in these negotiations, guess what? The only time you're going to find out your plan changes is when you get a memo in the mail because someone did something to change your benefit that's going to affect you. It'll probably benefit them, but it's not going to benefit you. Sorry, this is basically what's happening around the country, and we need you to help us advocate for protection of traditional Medicare, not for Medicare Advantage. It should be a choice the way it was intended, the way it was founded, not to be forced down someone's throat. Our organization is the New York City Organization of Public Service Retirees. Our website is www.nycretirees.org. We will put up a page on our website welcoming people who want to learn about this because we've been approached from people all across the country that are dealing with this. Stay strong. Reach out to us. We can put you in touch with our attorneys, show you what we did, how we did it, so that you can fight back. Good luck.